Hello everyone, good morning. Dr. Rajarathna here. So we will do the corneal questions discussion today. Shall we start? Are people joining us? Good morning everyone. So how was the question, guys? Questions were kind of okay-ish. Alright, so we'll start with the first question. Which of the following is a sign of impending corneal perforation? So impending corneal perforation. Hi, who's this? Hi, Monica. Hello. Alright, so the first question is which of the following is a sign of impending corneal perforation? That means the corneal perforation is about to happen. Okay. Uh, shall we discuss the options? Hello. Hi, Umesh. Hello, Umesh. All right. So option A is corneal vascularization. See, corneal vascularization is a sign of healing of corneal ulcer. It's not a sign of perforation, impending perforation. Okay. So anyway, let's look at option B. Option D, anterior staphyloma. See, anterior staphyloma is a complication of perforation. After perforation, probably, or even before perforation, without perforation also it can happen, but that is when the cornea is thinned out, and it's again a process that occurs during healing. It's not a sign of impending perforation. Decimetocele. What is decimetocele? Decimetocele is the corneal ulcer has reached up to the Descemet's membrane, and Descemet's membrane being the strongest layer is resisting the ulcer. Okay, it's resisting the effect of the ulcer, but behind it has aqueous. So the aqueous pressure is pushing that Descemet's membrane like a small cyst or a sac. So it is protruding like a sac. So anytime it can perforate if I don't manage the corneal ulcer, if I don't bring down the proteases in that area, because the proteases are dissolving the collagen and causing perforation. If I have to decrease the intraocular pressure. I should ask the patient not to cough or sneeze. Yes, so all that. So decimetocele, yes, that is a sign of impending perforation. Next step is perforation. Okay, but anyway, let's look at the last option, guttata. What is guttata? Guttata is Descemet membrane protrusion on the other side. Excrescences on the other side. It raises the endothelium also, and it's on towards the aqueous side. Okay, it's not towards the anterior, it's posteriorly. So guttata are Descemet's membrane excrescences, which are typically seen in Fuchs endothelial dystrophy, the central guttata. Okay, peripheral guttata, periphery cornea, you can see it in old age. It's a sign of old age, which is called Hassel-Henle warts. So what is the answer to this particular question? Our question was, which of the following is a sign of impending corneal perforation? Decimetocele. Okay, so decimetocele, if I ask you a question also, the management would be just like corneal ulcer. Okay, so you decrease the intraocular pressure, you put a soft bandage contact lens on the patient's cornea, and probably, yes, you continue the ulcer treatment, then give the patient vitamin C, give the patient doxycycline probably. Yes, so all this is part of management, and probably plan for amniotic membrane graft or a conjunctival flap. Yes, so all this is part of the management, just like corneal perforation ka management. Okay. Next one, RGP lenses are used to manage. First of all, what is RGP lens? Rigid gas permeable contact lens. Okay, rigid gas permeable contact lens. So it is used to manage Fuchs endothelial dystrophy, keratoconus, megalocornea, limbal dermoid. How do you manage Fuchs endothelial dystrophy? The treatment of choice is an endothelial keratoplasty, or if there is stromal scarring, then you do a full thickness penetrating keratoplasty. Okay. So Fuchs endothelial dystrophy, what is the management? It is not contact lens at all. Yeah. So you either do a lamellar keratoplasty, which would be a posterior lamellar keratoplasty, where you do an endothelial keratoplasty, endothelial corneal transplant. You do an endothelial transplant. Or if Fuchs has gone to an advanced stage where you will see stromal scarring. So stromal scarring means it's going to stay forever. That stromal opacity is going to stay forever. So only replacing the endothelium is not going to work. It's not going to improve the vision of the patient. So we'll have to do a full thickness keratoplasty or a penetrating keratoplasty. Yes. So no role for RGP ever. Alright. Contact lens ever. Keratoconus, yes. See, keratoconus, the classic refractive error is irregular astigmatism. So for irregular astigmatism, you'll have to give rigid gas permeable contact lens. Yes. Now, why is it rigid? Because it has PMMA as a material. Yes, PMMA, polymethyl methacrylate. Now, why is it gas permeable? Because it also has silicone polymers along with it, which makes it, the oxygen diffusion capacity is more. So your cornea gets your oxygen from the air, atmospheric air. So when I have a nice softer material, the oxygen can diffuse. So that is why we call it gas permeable. So RGP lenses are made up of PMMA along with silicone polymers. Is that clear? So RGP is essentially for keratoconus when it has reached the irregular astigmatism stage. Before that, we can give the toric soft contact lenses, but once it reaches the irregular astigmatism where we cannot control it with, we cannot manage the give a better vision with toric contact lens, then we go for RGP contact lens. So I think that is the answer. But anyway, let's look at option C, megalocornea. See, megalocornea itself does not need any management. Now, if megalocornea is associated with ophthalmos like congenital glaucoma, then you will have to treat the intraocular pressure. Yes. So megalocornea itself, yes, it is an X-linked condition. It can occur, megalocornea per se. But as long as there is nothing associated with it, you don't have to manage megalocornea as such. Alright. Okay. Option D, limbal dermoid. Limbal dermoid, what do you need to do? You need to excise the dermoid. There's no role for RGP lens on that. Yes. Yes, limbal dermoid can cause astigmatism because of the compression that it causes. Yes, it can cause, but you will have to definitely excise the limbal dermoid and then decide whether the patient needs any further optical management for vision. Is that clear? Okay. Now next one, collar button abscess. Collar button abscess is seen in keratitis due to. See, collar button is like, there's one button type, one mass, it's like that. So collar button abscess, it's like a pus, like one block of pus. Yes. So collar button abscess is due to what type of keratitis? Okay. Aspergillus. See, aspergillus is a fungus. It is a filamentous fungus. What do these filamentous fungi cause? They cause this dry, leathery, feathery margins, that kind of corneal ulcer, which is very rough looking. Good morning, BU. Good morning. Beta, the TMD is live on the app. I think 6 o'clock it was live. I hope you've taken the test, and the discussion I will upload by 5 to 6 p.m. Okay, on the app. All right. All right. So collar button abscess is seen in not seen in aspergillus, because aspergillus causes a dry, rough corneal ulcer with feathery margins, a typical ulcer. Hi, Varsh. Who is this? Vanshi. Ajay. All right. Vanshi. Hi. Okay. Candida is a fungus. Yes, it is a dimorphic yeast. Yes, that is what it causes, this collar button type of abscess. But anyway, let's look at the other options. Acanthamoeba. Acanthamoeba, typical ring-shaped abscess. It's a ring, not a collar button. Collar button will be like a plaque. Okay, like one solid round pus. HSV, herpes simplex causes your dendritic ulcer, your geographic ulcer, then your nummular keratitis and disciform keratitis. Nothing to do with collar button. Yes. So collar button abscess is caused by your dimorphic yeast, which is Candida albicans. Yes. Where else do we have this collar button description? Collar button type of tumor. Yes, collar button or collar stud tumor. What is the answer? Collar stud type of tumor. This is not cornea, but anyway, this collar button or collar stud appearance. Where else do we use in ophthalmology? I told you it is a tumor. Now, what is the answer? Please put it in the chat box for me. Alright, in the meantime, I'll take up the next question, which is all of the following are responsible for corneal transparency. See, corneal transparency is a very, very, very important topic. Okay. So they are asking for all of the following are responsible except, okay. Option A, regular arrangement of stromal collagen. Is it responsible for corneal transparency? Yes, of course it is. So it is not the answer. Option B, endothelial pump. Yes, endothelial pump is your sodium potassium ATPase pumps, which is present in the corneal endothelium. What does it do? It does not pump water, but it pumps out ion. So there is an active ion movement. Following that, there is a passive water movement from the corneal stroma into the aqueous. So the cornea is relatively dehydrated, and that is very, very important for the transparency of cornea. Yeah. So that is not our answer. Option C, absence of lymphatics. See, yes, that is very, very important. We don't have lymphatics in the cornea. We don't have lymphatics because lymphatics, as you know, it carries chylomicron. Chylomicron is fat. Now, I don't want fat moving on my cornea. I will lose my transparency, right? So that again contributes to the transparency of the cornea. So I definitely know whatever is in option D is our answer. Let's see what is there in option D. Myelinated corneal nerves. No, corneal nerves are actually unmyelinated. That is why again it contributes to corneal transparency. So it is not myelinated corneal nerves. So that is our answer. So actually the corneal nerves are unmyelinated. They are not surrounded by the myelin sheath. Okay. Very, very important. All right. Very good. Who answered that? Monica, very good. Ajay, very good. Melanoma, malignant melanoma of uvea. Uveal melanoma or choroidal melanoma looks like this collar button tumor. Okay, it looked like a mushroom or a collar button. So we describe it as a mushroom, or typically, originally we used to call it as a collar button tumor. Very good, guys. Very good. I'm so glad. Alright, we'll take up the next question. Metabolism of glucose in cornea. How is glucose metabolized? Yes, in the cornea. Aerobic glycolysis, option B. Anaerobic glycolysis, option C. HMP shunt, option D. Sorbitol pathway. So the main mechanism, see, cornea has access to oxygen. Yes, oxygen in the atmosphere. So it is aerobic glycolysis. Yes, aerobic glycolysis mainly. But can anaerobic glycolysis also happen? Yes, it does happen, because when we sleep, our lids are closed. So we do not have access to the atmospheric air, right? So that means my cornea needs to survive for that 6 to 8 hours that I'm supposed to sleep. Yeah, I don't know how long you guys sleep, but okay, the beauty sleep 8 hours or at least 6 hours is medicose. So that 6 to 8 hours, we should be able to, a cornea should be able to manage without accumulating lactic acid, because anaerobic glycolysis is lactic acid is the end product, correct? So it can survive, but for 6 to 8 hours. But primarily it is aerobic glycolysis. Okay. So anaerobic glycolysis also does happen without undue side effects for around 6 to 8 hours. But what is the main mechanism of metabolism of glucose? It is aerobic glycolysis. Is that clear? All right. Treatment of choice for viral stromal keratitis. Viral stromal keratitis, what are the two entities? Guys, are you following me so far? Give me a thumbs up if all that I have discussed so far is perfectly crystal clear to all of you. Crystal clear, so that I can move to the next question. So the viral stromal keratitis, we have two entities. One is nummular keratitis and another is your disciform keratitis. Yes. Now both of them are hypersensitivity to the viral antigens. Thank you, BU. Very good. So they are hypersensitivity to the viral antigens. Yes. So whenever it is hypersensitivity, we know pharmacology basics. What do you give for hypersensitivity? Anything and everything, hypersensitivity, allergy, you can always give steroids. So the treatment of choice is steroids. Okay, topical steroids. Anyway, let's look at the options. Oral acyclovir, not needed. You may give topical acyclovir, you may give, but oral acyclovir definitely not needed. Topical acyclovir, yes, you can give, but my question is very specific, treatment of choice. Okay, treatment of choice is what you give for the underlying pathophysiology. Option C, topical prednisolone. Is prednisolone a steroid? Yes, topical prednisolone, because topical steroids is the drug of choice or the treatment of choice for my viral stromal keratitis, be it nummular keratitis or disciform keratitis. Last option, topical home atropine. You might give it clinically if you feel there is an attendant. Also, there is some kind of iridocyclitis, some iritis is there. That is clinically we decide. But treatment of choice is topical prednisolone. Okay. Alright, now next question, most common endothelial dystrophy. So many times I have told you this. Most common endothelial dystrophy, which I also discussed in the first question. Which is the answer? Fuchs endothelial dystrophy. Okay, Fuchs endothelial dystrophy. And Fuchs endothelial dystrophy is characterized by what? By central gut data. What are gut data? Gut data are decimate membranes excrescences present centrally. Central DM excrescences. Okay, let's take a look at the options. Option A, fingerprint map dot dystrophy. Is it first of all an endothelial dystrophy, guys? No, not at all. It is an epithelial dystrophy. That is your Cogan's dystrophy, also known as Cogan's dystrophy, or the present nomenclature, which is EBMD, epithelial basement membrane dystrophy. So that is the most common epithelial dystrophy. But my question is, what is the most common endothelial dystrophy? Option B, posterior polymorphous dystrophy. PPMD is again an endothelial, but that is not the most common. Option C, Fuchs endothelial dystrophy. Yes, that is the answer. Option D, CHED, congenital hereditary endothelial dystrophy, but that's not very common. Yes, does interstitial keratitis also? Yes. See, the definition of who's this? Ajay, yes. Interstitial keratitis by definition is interstitium. Interstitium means stroma. Interstitium means stroma. Okay. The definition is without epithelial or endothelial involvement primarily. That is interstitial keratitis. Okay. Interstitial is primarily a stromal keratitis without endothelial or epithelial involvement. Okay. That is interstitial. Okay. Let's move on to the next question. Linear branching ulcer with terminal knobs are pathognomonic of. So what are we actually describing? Linear branching like a tree with terminal knobs, terminal dilatations or terminal bulbs. So we're talking about true dendrites. So true dendrites are seen in, you know the answer. Let's look at the options. I hope you know the answer. Type the answer. Very good. Very good, Ajay. HSV keratitis. Very good. Anyway, let's look at the options. Option A, herpes simplex virus. Yes, you see true dendrite with that terminal knob or the terminal bulb or the terminal dilatation that is seen in herpes simplex virus. That's a true dendrite. Yes. Pseudodendrite you see in varicella zoster virus, VZV. Option B, VZV. No, VZV, there is no terminal knob, right? Okay. So our answer is option A, adenovirus. No. Acanthamoeba, you can get dendrites, but that will be a pseudodendrite. You can get pseudodendrites in acanthamoeba. That's another learning point for you. Can we move to the next question? Yes. Hutchinson's sign is due to involvement of. What is Hutchinson's sign and where is it seen? Which condition it is seen? You put in the chat box. By that time, we'll discuss the question. So Hutchinson's sign is due to involvement of option A, trigeminal nerve, option B, oculomotor nerve, option C, facial nerve, option D, nasociliary nerve. Very good. It is seen in, very good Ajay, it is seen in herpes zoster ophthalmicus, not just herpes zoster, herpes zoster ophthalmicus, HZO. Very good. And it is due to involvement of which nerve? Nasociliary nerve. So what exactly is your Hutchinson's sign? Hutchinson's sign is, if you see a hepatic lesion, you know those fluid-filled vesicles. If you see a hepatic lesion either at the tip of the nose or the root of the nose, you know, that's a textbook description. If you see it anywhere here, you always suspect a corneal involvement. There is most likely a corneal involvement. That is a Hutchinson's sign or Hutchinson's rule, and that is because of the involvement of nasociliary nerve. Very good. Now, scissoring reflex is seen on. So that means they are asking about which investigation. Now, in the meantime, you will tell me in which condition do you see scissoring reflex. Now, scissoring reflex is seen on option A, distant direct ophthalmoscopy, option B, retinoscopy, option C, gonioscopy, option D, placido disc. Yes, very good. Very good, BU. Very good, Ajay. So you see scissoring reflex in keratoconus. Keratoconus, the earliest clinical sign of keratoconus is scissoring reflex. Okay, scissoring reflex, and it is seen on retinoscopy. Yeah, seen on retinoscopy. Now, on distant direct ophthalmoscopy, do you see any finding in keratoconus? Yes, we do see the oil droplet reflex, that is on distant direct ophthalmoscopy. On retinoscopy, you see the scissoring reflex. Is that clear? Yes, very good. All right. So, guys, the test and discussion series is on the app. So, if anybody wants to join that, you can DM me either on my Telegram or my Instagram handle, or you can just ping us on the app. All right. We will add you to the batch. You can join us. And the Christmas offer is on. I guess it's there for another 1 or 2 days. So make good use of the offer again. Tomorrow we will have, today we will have lens quiz at 6 p.m. on my Telegram group. And tomorrow, as always, I will see you at 11 here. 11 we'll have the lens quiz discussion. All right. So have a good day, all of you. Study well. Have good thoughts in your mind. That is very, very important. Be positive. All right. See you. Ciao. See you tomorrow. Ciao, ciao. You're most welcome. You're most welcome, Ajay.